Hello, today we're going to be talking about transitioning negative pressure wound therapy patients to the post-acute setting. A little bit about me. My name is Dr. Robert Klein. I've been practicing wound care and amputation prevention for a little over 29 years. I serve as the division chair for wound care at Prisma Health Upstate. We are the largest not-for-profit healthcare system in South Carolina. I also serve as the medical director for the Vascular Health Alliance and Wound Healing and Hyperbaric Oxygen Center in Greenville, South Carolina. And I'm faculty at the University of South Carolina School of Medicine in Greenville. I serve as a clinical assistant professor of surgery. These are my disclosures. Some program information. This program is provided by the North American Center for Continuing Medical Education, LLC, an HMP global company. And this program is supported by an educational grant from 3M Healthcare Medical Solutions Division. Our learning objectives with respect to this talk include examining the prevalence of hospital readmissions, their economic impact on the healthcare system, and the importance of preventing readmissions to improve wound healing. We'll explore the common challenges associated with discharging a patient with negative pressure wound therapy to the post-acute setting, and steps that we can develop to come up with a comprehensive discharge plan. We'll analyze comparative effectiveness differences across negative pressure wound therapy suppliers and wound-related and total cost to treat patients who receive durable negative pressure wound therapy in the outpatient setting. And then lastly, we'll examine some case studies of mine that utilize negative pressure wound therapy to optimize wound healing. Common wounds that I treat as a podiatrist include diabetic foot ulcerations. The wounds that I'm going to go over this evening are not all-inclusive for negative pressure wound therapy, but I wanted to go over some of the wounds that I routinely treat at my wound care center and in the hospital setting. So certainly diabetic foot ulcerations are common ulcerations that I see, and these are wounds that can and do benefit from negative pressure wound therapy. Surgical wounds, wounds that I create or my partners create. I'm at a teaching institution. I work with vascular surgeons, general surgery residents, and interns. And oftentimes I'm consulted on surgical wounds, and negative pressure wound therapy is a common modality that I use to close these wounds. Wound dehiscence, wounds that either I've created or my partners or colleagues have created. Wound dehiscence is something that is increasing, at least at our institution in South Carolina. And negative pressure wound therapy is another modality that is very, very beneficial to treat wound dehiscence. Pressure ulcerations, ulcerations that are a result of pressure, have depth, have exudate. These are wounds that as well can benefit from negative pressure wound therapy. And lastly, venous ulcerations. These are highly exudative type of wounds. They have fibrinous material, cellular debris, infectious debris. Sometimes they have depth, and these are wounds that as well that can benefit from negative pressure wound therapy. Again, this list by no means is all-inclusive, and we will talk about indications for negative pressure wound therapy later in this talk, but I wanted to go over some of the common wounds that I see routinely at our wound care center and that benefit from negative pressure wound therapy. As a podiatrist, what I'm trying to avoid is amputation. Now, obviously, people who are listening to this lecture might not be treating just lower extremity wounds, but negative pressure wound therapy is something that you can use across the board. But within my specialty, amputation prevention and loss of limb is what I'm trying to avoid. And these, sadly, are patients that I see every day in my practice. Wounds in the United States. And this is data from 2014, so this number is actually probably higher. But at any given time, there are roughly 6.5 million people in the United States that are living with a chronic wound. And the cost of the system is enormous, $50 billion impact annually on the healthcare system to take care of chronic wounds. Each year, 14.5% of Medicare beneficiaries experience a wound, and that number is likely increasing with our aging population, the increased incidence of diabetes, and just the prevalence of wounds that we're seeing across the board, wound dehiscence, surgical wounds. So that number likely is increasing with time. And these stats are from 2014, so I'm quite sure that that number is likely higher. If we look at diabetes and wounds, roughly 10.5% of the United States population, at least the most latest data that I have is from 2019, are diabetic. So again, 10.5% of the population is diabetic, and that translates into roughly 34.2 million Americans that are suffering with diabetes. And we know that diabetic patients have problems with wounds. and oftentimes lower extremity wounds. The cost of the healthcare system is enormous. $237 billion of direct costs to medical care and taking care of our diabetic patients on any given year. If we get a little bit more granular and focus to just diabetic foot ulcerations, the cost for diabetic foot ulcerations in 2018 was roughly somewhere between $9 and $13 billion annually just to take care of diabetic foot ulcerations. So again, the cost of the healthcare system is just staggering. The Hospital Readmissions Reduction Program. This is a program that's part of the Patient Protection and Affordable Care Act, and you can find it in Section 3025. It supports the national goal of improving healthcare by linking payment to the quality of healthcare. It's basically a value-based purchasing program, and it encourages hospitals to improve communication with patients and their providers. It also encourages better communication and to engage providers and their patients in discharge plans with the ultimate goal of reducing avoidable readmissions to the hospital. As I shared, it's part of the Affordable Care Act, and it began on October 1st of 2012. And it was designed as a means to bend the healthcare cost curve. And in essence, what happens is hospitals are financially penalized if they have a higher than expected risk standardized 30-day readmission rate. Currently, 6 diagnoses are being followed by the Hospital Readmissions Reduction Program, and these diagnoses include acute myocardial infarction, chronic obstructive pulmonary disease, heart failure, pneumonia, status post-coronary artery bypass grafting or CABG surgery, and elective primary total hip arthroplasty and total knee arthroplasty. And the payment reductions are capped at 3%. Now, what does CMS define as a 30-day readmission, or what counts as a readmission under the Hospital Readmissions Reduction Program? And in essence, really any unplanned readmission that happens within 30 days of discharge from the initial or index admission to the hospital. And these can be patients who are readmitted to the same hospital, or these could be patients that are admitted to another applicable acute care hospital for any reason within those 30 days. And again, these are CMS definitions for a 30-day readmission. The Agency for Healthcare Research and Quality, AHRQ, has estimated that readmissions are reaching $41.3 billion annually for patients who are readmitted to the hospital within 30 days of their discharge. The Center for Health Information and Analysis estimates that hospital readmissions cost Medicare about $17 billion unavoidable, once again, unavoidable hospital trips after discharge. So the impact on readmission is real and it's significant to the healthcare system. In 2019, data was published which showed that in the year 2015, 1 in 5 elderly patients were readmitted to the hospital within 30 days of their discharge. So basically 20% of the patients were readmitted to the hospital within 30 days. CMS penalized over 2,500 hospitals by more than $564 million in 2017 for excessive 30-day hospital readmission rates. Now, CMS is just not the only one that's looking at readmission. I know we had talked about 6 diagnoses that CMS is following with respect to the HHRP program, but our healthcare systems are also looking at readmission rates. They're partnering with insurance companies and they're partnering with CMS through Advantage plans to share risk with respect to healthcare, to improve quality of cost, to decrease length of stay. So the healthcare systems that we work at are looking at us as well as the insurance companies to reduce readmissions as well. So let's talk about readmissions and wounds themselves. There's a lot of data out there and articles that have been published that talk about readmissions and wounds. We know that CMS is tracking 6 diagnoses right now, but at some point that list is probably going to get larger, and it may at some point include wounds as well. And as early as 2013, a year after the HRRP program was started, we started seeing literature pop up that talked about readmissions and wounds. And in 2013, Vogel published an article on the risk factors for readmission after lower extremity procedures for peripheral arterial disease. So we're now getting closer into our segment of wound care. And what Vogel discovered or reported on was that predictors for readmission include length of stay in the hospital, if the patient developed a hospital-acquired infection, and if the patient had high numbers of medications that were ordered while they were in the hospital, and also medications that were dispensed to the patient after they were discharged from the hospital. Looking at additional literature with respect to readmissions and wounds, Holscher in 2018 published an article on unplanned 30-day readmission in patients with diabetic foot wounds treated in a multidisciplinary setting. This was published in the Journal of Vascular Surgery. Now, you would think that patients that are treated in a multidisciplinary setting with diabetic foot ulcerations would have a low readmission rate. And what Holscher reported was that 17% of the patients in their study had an unplanned 30-day readmission rate, and they're diabetic foot ulceration patients that were enrolled in a multidisciplinary diabetic foot service. So once again, almost 1 in 5 patients wound up with a readmission into the hospital, data that's supporting the other study that we talked about a few minutes ago. The last article that I want to talk about with respect to readmissions and wounds was an article that Caitlin Hicks published in 2019 in the Journal of Vascular Surgery, and it talks about the contribution of 30-day readmissions to the increasing costs of care for the diabetic foot. And what Dr. Hicks reported was that readmissions for patients with diabetic foot ulcerations are common, and they also come with substantial costs when they are readmitted to the hospital. In fact, the cost of readmission for the patient with a DFU or a diabetic foot ulceration was as high as the cost of the initial admission or that index admission to the hospital. Lastly, what Hicks reported was that we need to have focused efforts at preventing readmissions. They're essential to reducing the overall costs of care for the diabetic foot ulcerations. And again, I can tell you that our institutions are looking at this very carefully. Our insurance companies are looking at this very carefully. And we as medical specialties are studying this and looking at this very carefully. So how do we improve hospital readmissions? And that really starts at the time that the patient is admitted to the hospital. We all have case managers and social workers that we're working with at our institutions, and they really start to focus on the discharge plan when the patient really is admitted to the hospital. And that's an important component to improve hospital readmissions. Other essential components to help reduce readmissions to understand the patients who are at risk for readmission to start with. And those patients that are at risk for readmission include our older patients, 65 years and older. We know that these patients are typically more sicker. They have other comorbid medical problems. So these are patients that are at risk for readmission. Those patients who have an unstable living condition or living situation. I have patients that live in pickup trucks. I have patients that live in cars. I have homeless patients. I have patients that live with family members or live with friends and they go from house to house. So these are unstable living situations, and these are patients who are certainly at risk for a hospital readmission. Our patients who have either low English or health literacy, if the patient doesn't understand their condition, if they don't understand the language and they don't understand what their condition is, they're certainly at risk for readmission. So engaging our hospitals to help with translation and health literacy is important to reduce readmission rates for these subset of patients. Our frequent flyers to the emergency department. We have patients who don't have primary care providers, or don't have access to other providers other than the ED or perhaps the hospital. So these people use the emergency department as their primary care provider. So patients who have frequent emergency department visits are at a higher risk for readmission. Patients who are discharged 6 or more medications have a higher rate of readmission. These are patients who may not take medications as prescribed, have difficulty with it, may develop adverse reactions from these multiple medications. So these are patients that might wind up in the emergency department or might wind up with a readmission to the hospital. Our sicker patients, our diabetic patients, our patients with heart failure, we looked at the HRRP program, and the HRRP program is studying patients who have heart failure because they have a high rate of readmission. So we know that our sicker patients, our diabetic patients, our heart failure patients are at risk for readmission to the hospital. Our patients who are poorly nourished, disabled, or frail, these are patients that aren't going to do well at home, and they certainly are at a higher risk for being readmitted to the hospital. And then lastly, patients that are discharged over a holiday or a weekend. These patients go home, they might have a problem, they don't know what to do, they don't have access to their primary care provider or their surgeon. These are patients that might wind up in the emergency department and ultimately wind up being readmitted to the hospital. Real life readmission challenges. I picked a couple patients that I see in my clinic, and I just wanted to use them as examples of real life readmission challenges. On the left part of the slide, you can see the medical conditions that this particular patient has. This patient has multiple diagnoses, including diabetes with neuropathy, diabetes with kidney disease, and stage renal disease that ultimately went on to a kidney transplant. The patient has hyperlipidemia. The patient had a CABG procedure. The patient has an ulceration on their foot that goes down to joint capsule. This is a patient that has multiple comorbid medical problems. Once again, a high acuity patient. If we look at their medication list, you can see that the patient is on more than 6 medications, including prednisone and Graft, immunosuppressive type medications. This is a patient who, once again, might have difficulty taking the medications that they're already on, let alone anything else that we prescribe to them when they're in the hospital. The last part of the slide, at the bottom left-hand corner of the slide, is just their hemoglobin A1c. 8 months ago, the patient's A1c was 9.9. 5 months ago, the patient's A1c, instead of trending down and doing better, actually trended up and was 11.2. And just 2 weeks ago, the patient's hemoglobin A1c was 11.1. This is going to be a patient who has a hard time healing any type of surgical wound and might be a real life readmission challenge once they're discharged from the hospital. Another real life readmission challenge. This is a diabetic patient who's currently under my care, and we're going to look at this case a little bit more closely later on in the lecture. But you can see on the top right photo, the patient has a diabetic foot ulceration that probes deeply into the soft tissues, essentially almost down to bone. The patient has circumferential undermining. The patient has infection. So this patient was admitted to the hospital and was taken to the OR for debridement. The patient ultimately was discharged on 8 medications, and the patient was discharged with a negative pressure wound therapy system. But if we look a little bit deeper into the patient, we can see that this is a complex patient. The patient weighs 494 pounds. The patient has a high BMI. This is going to be a high-risk patient for readmission. If we look at their hemoglobin A1c, it's 11.5. It's nearly twice or over twice the normal range for a diabetic patient. This is going to be a patient who has a hard time healing this wound, hard time dealing with his negative pressure wound therapy system, perhaps. So he's at high risk for readmission to the hospital. If we look at him from a nutritional perspective, his serum albumin is 2.8 and his prealbumin is 11.5. Wound healing is going to be a challenge for this patient. So when you factor in all of these conditions, this is definitely a real-life readmission challenge. So we need to come up with strategies to prevent readmission. And when we think about strategies to prevent readmission, we want to assess the patient's post-hospital needs. And when we do that, we need to involve both the patient and the family. And when I say both the patient and the family, I mean that very sincerely, because the patient may not know of all their needs that they might require at home. They may have someone who's taking care of them, and we need to engage the family to find out what their home life is or what their needs are after they're discharged from the hospital. We need to reconcile their medications at the time of admission to make sure that the patient's taking the right medications. And certainly we want to reconcile their medications at discharge, because they might be discharged with new medications. They might be on a new insulin regimen. They might be on antibiotics that require taking multiple dosages throughout the day, or they might be on multiple antibiotics requiring different dosages throughout the day. We also need to identify the patients who are at risk for readmission. Those patients that we talked about briefly are frail, are malnourished patients, are patients who have multiple medications, patients who have situations where their lifestyle or their home environment is not ideal. So we need to identify those patients to assess them and their risk for readmission. And lastly, we want to create a patient-specific discharge plan. These are strategies that we can do to help prevent readmission. Other strategies that we can do to help prevent readmission include teaching and learning episodes for the patient. You want to involve all the learners in the patient's care. This once again includes the family members, because they might have a spouse or a child or a friend that might be taking care of them when they're discharged from the hospital. And things that we employ at our institution are teach-back techniques throughout their hospital stay. Say, for instance, when the patient is having their wound vac applied, and we turn the wound vac on and we hear the alarm go off indicating that there's a leak. This is a great opportunity for us to teach back to the patient that maybe we need to take an extra piece of drape and secure down that negative pressure wound therapy system to get that leak to stop. So utilizing teach-back techniques throughout the hospital stay is a great tool to educate our patients and to help prevent readmission to the hospital. we think about additional strategies to prevent readmission, we want to ensure that the patient has post-hospital care follow-up. We certainly want to reassess the patient's medical and social risk for readmission. Once again, that patient may have an unstable living environment. So we might want to engage the social worker to see if we can get them placement at a skilled nursing facility or a rehab facility to prevent readmission to the hospital. We also want to schedule follow-up care for the patient to make sure that they have continuity of care when they're discharged from the hospital. And we certainly want to initiate any clinical or social services. We might need to engage physical therapy, for instance. We might need to engage home health. Again, the patient might need a placement at a skilled nursing facility, or if they don't have a home, they might need to get help with a social worker to get them to a place where they can get the care they need, and also to prevent extended lengths of stay at the hospital or readmissions to the hospital. Lastly, in our readmission prevention strategies, we want to provide adequate and good handover information to our patients. And we want to give that both to the patient and any family members or caregivers that are going to be taking care of the patient. And these should be easy to understand post-hospital discharge plans. Again, we want to provide the patient with an updated medication list. We want to go over with them to make sure that they understand what medications that they need to take and when they need to take them. And we should provide critical information to the next care provider. That could be something as simple as sending a discharge summary via our electronic medical record and sharing with a provider who's within our healthcare system. Or we may need to pick up the phone and call the next provider and say, hey, listen, I took care of Mrs. Smith in the hospital. She has a negative pressure wound therapy device. She's malnourished. I want to give you a heads up on this particular patient and some of the challenges that she has so that we can hopefully prevent readmission to the hospital. So providing critical information to that next care provider is essential as well to prevent readmission. Negative pressure therapy and wound healing. Negative pressure wound therapy has been studied across multiple care settings and wound types. We're now in our third decade of use with negative pressure wound therapy. And if I had to think of one modality or one wound care device or something that I use within my toolkit that has just changed the way that I address wounds, I have to say it's negative pressure wound therapy. When I was sharing my information with you, I've been practicing wound care for 29 years. And I remember as a resident using wet to dry dressing changes for our patient. Negative pressure wound therapy has been a game changer for me in how I treat wounds. I'm able to close my wounds much more quickly with negative pressure wound therapy, and I'm able to decrease the length of stay at the hospital with negative pressure wound therapy. And I'm also able to save money to the healthcare system by utilizing negative pressure wound therapy. We had talked about some common wounds briefly for negative pressure wound therapy. I'd like to go over the indications for negative pressure wound therapy in more detail. Negative pressure wound therapy is indicated for chronic wounds, acute wounds, traumatic wounds, partial thickness burns, wound dehiscence or dehisced wounds, and ulcerations that we commonly see, including our diabetic foot ulcerations, our venous leg ulcerations, our venous foot ulcerations, and pressure ulcerations. Negative pressure wound therapy is also very beneficial for flaps and for grafts. Common misconceptions about negative pressure wound therapy. One of the more common things that I hear from providers who just aren't well versed with negative pressure wound therapy is that it should only be used when other modalities fail. And that's the furthest thing from the truth. In my opinion, negative pressure wound therapy should be instituted early, and it shouldn't be used as the fail-safe when other modalities fail. We've seen over time and through the literature that negative pressure wound therapy actually decreases the time that it takes for wounds to heal. It can decrease length of stay at the hospital, and certainly can optimize our wounds for other treatment modalities. Other misconceptions about negative pressure wound therapy include that it's only for large wounds. Again, that's not true. I find that size does not matter when it comes to wounds, and in fact, smaller wounds sometimes can be as troublesome, if not more troublesome, than larger wounds to heal. So when you have a small wound, I think it's important or incumbent upon you that you should think about negative pressure wound therapy to close these wounds. A brief primer on negative pressure wound therapy. We know that negative pressure wound therapy works through both macro strain and micro strain. We put a sponge in the wound, we put negative pressure on the wound, and we basically are sucking on that wound. We're getting macro deformation of that wound. When we get that macro deformation, that decreases the wound margin. It removes exudate or fluid from the wound, and it also decreases edema around the wound. And we know that edema impairs or delays wound healing, so it helps with edema. If we look at microstrain, we get microdeformation of the wound as well, and that helps promote granulation tissue, and at the same time, it increases blood perfusion to the area of the wound, which again promotes granulation tissue and gets that wound to heal. So negative pressure wound therapy, again, just in short, works with both macrostrain and microstrain. When we think about our negative pressure wound healing strategy, again, I just want to emphasize that it should be used as early as able. It really does set the stage for rapid healing, and it helps prepare the wound for other advanced wound care modalities, which can include split thickness skin grafting, cellular tissue products, or using advanced wound care dressings to take our wounds onto closure. When I was a resident, I had an attending who had a couple different sayings. One was, all bleeding stops eventually. Any two bones in one wound will heal eventually, and time heals all wounds. And I don't think any of those three are essentially true. But time, when you think about the time acronym, time can heal many wounds. And the time acronym stands for tissue, infection, inflammation, moisture imbalance, and edge. And this was described by Greg Schultz in 2004. He published an article on wound bed preparation and a brief history in time. And he talked about the importance of debriding tissue, taking all of that non-viable and necrotic tissue off to help wounds to heal. He talked about addressing infection, treating infection with the appropriate antibiotic coverage, but also addressing infection, those MMPs that are in the wound that can delay or stall wounds. He talked about moisture imbalance, and in 2004, when he published the article, it was more about using advanced wound care dressings to work with moisture imbalance. And we'll talk about that a little bit more in our next slide. And then lastly, he talked about the edge, taking care of that non-advancing edge or that undermining edge, debriding that to make sure that you can get keratinocytes to migrate across the wound. And that was in 2004. Well, Greg Schultz revisited that article with Lepper and his group at the University of Florida in Gainesville. And he talked about extending the time concept, what we have learned in the past 10 years. And we learned that tissue management is still very important. We still have to take off that bad tissue. And we also confirmed that taking care of infection and inflammation is an essential component to wound healing. And we still know that the edge is an important part of that wound healing strategy. But what Schultz also discovered was that negative pressure wound therapy has become increasingly much more prominent in wound management. We know that these wounds are highly exudative type of wounds, and using negative pressure wound therapy is just a great tool to manage that exudate and get that wound to contract. So looking at the time principle 10 years later, negative pressure wound therapy has become a very prominent part of that time acronym or that time principle for wound bed preparation. And here's the time principle in action. This is the patient that we talked about before. It's a diabetic patient with a Charcot foot. You can see he's got an ulceration that probes deeply into the foot, basically to bone. He's got circumferential undermining. This is a wound that needs to be debrided. It needs to be treated with antibiotics. It needs moisture control, and it also needs the edges to be addressed. So here's the patient preoperatively. The patient was taken to the OR and went a fairly aggressive debridement. The patient has exposed deeper structures. We have a very large wound that has depth, that has exudate. This is a wound that would benefit from negative pressure wound therapy and benefit from it early versus later. So the patient was started on negative pressure wound therapy post-op day 1. We have the negative pressure wound therapy device on. We're getting both macro deformation and micro deformation of the wound. We're controlling that exudate by sucking on the wound, getting rid of that exudate, and we're getting contracture of the wound as well. You can see that both through macro deformation and micro deformation, we got granulation tissue that has formed and it's developed the skin line. And this is a wound that we can now use either a split thickness skin graft or an advanced wound care dressing to take onto closure. In this particular patient, because the wound's on the bottom of his foot, you can see he's had a previous skin graft that did not work. I opted to use an advanced wound care dressing on him, collagen silver with ORC, and we're taking this patient onto closure. This patient is still under my care. So unfortunately, I don't have a slide where he's completely closed, but I'm quite confident that this patient will go on to closure. The biggest challenge is we can keep them closed because as we know, with diabetic foot ulcerations, 40% of them will re-ulcerate within 12 months. Negative pressure wound therapy has been studied extensively throughout the literature, and I'm just going to share a couple different articles with you during this talk. Carolyn Fife in 2008 published an article on the safety of negative pressure wound therapy using vacuum-assisted closure in diabetic foot ulcerations treated in an outpatient setting. So once again, the post-acute setting. And what she published was that negative pressure wound therapy is safe and effective for diabetic foot ulcerations in an outpatient setting. D. Oathman in 2012 published an article in the UK. It was a literature review on negative pressure wound therapy, literature review of efficacy, cost effectiveness, and impact on patients' quality of life in the chronic wound management and its implementation in the United Kingdom. And what she published was that there's clinical and economic evidence supporting the use of negative pressure wound therapy and wound management, including early discharge, faster healing, fewer readmissions to the hospital, better patient quality of life, and improved cost effectiveness. And once again, we talked about readmissions to the hospital and how we're being monitored as providers. We want to definitely reduce readmissions to the hospital. We want to improve the patient's quality of life. And at the same time, we want to improve the cost effectiveness to our healthcare system. Amy Law in 2020 published an article on the comparison of healthcare costs associated with patients receiving traditional negative pressure wound therapies in the post-acute setting. And this is a new study on negative pressure wound therapy comparing negative pressure wound therapy 3M or K versus negative pressure wound therapy O, the other negative pressure wound therapy systems that are available in the US. This was a retrospective analysis of National Insurance Claim Database conducted by Optum. 15,180 patients were analyzed who had an initial outpatient negative pressure wound therapy claim between January of 2016 and September of 2018. And patients were grouped according to the initial negative pressure wound therapy system that they received, NPWT-K, which would be the 3M system, and then NPWT-O, which are the other negative pressure wound therapy systems available in the US. The cohorts were propensity scored matched based on age, gender, comorbidities, and payer type. Each cohort after matching had 3,368 patients, and costs were evaluated at 30 days, 3 months, 12 months for NPWT-K versus NPWT-O. And what Ms. Law did was she evaluated total cost to treat across all time periods. Once again, this was at 30 days, 3 months, and at 12 months. And this was for wound-related costs and non-wound-related costs. And what she reported was that the total cost to treat is higher at all times in the NPWT-O group versus the NPWT-K group. 37% higher at 30 days, 32% higher at 3 months, and 30% higher at 12 months. Furthermore, wound-related costs were higher across all time periods for the NPWT-O group versus the NPWT-K group. 32% higher at 30 days, 36% higher at 3 months, and 37% higher at 12 months. Lastly, the negative pressure wound therapy expenditures were higher for the NPWT-O group versus the NPWT-K group, despite possibly a lower cost for the NPWT initially, indicating that the patients were on longer time of therapy with the NPWT group throughout all time periods. Looking at the comparison of the 3M to competitor negative pressure wound therapy system showed differences in total cost to treat across all wound types. The wound types studied included diabetic ulcerations, pressure ulcerations, which were the two largest segments of the study. It also included open wounds and non-healing surgical wounds. And what Ms. Law reported was that the total cost to treat and wound-related costs for NPWT-O was higher across each wound type at 12 months. Depending upon the wound type, it was between 21% to 34% higher. Wound-related costs represented between 43 to 53% of total costs to treat these chronic wounds. And the wound types were pretty much evenly split amongst the 3M NPWT system versus the competitor system. Once again, diabetic ulcerations and pressure ulcerations being the largest number of wounds. To summarize the NPWT-K versus the NPWT-O study, the total cost to treat and wound-related costs were between 30 to 37% higher, once again, depending upon the wound type, in all time periods for the NPWT-O versus NPWT-K. NPWT-O expenditures were higher across all time periods versus NPWT-K, and there were more NPWT-O patients that had a claim in each subsequent month following the initial outpatient claim, which indicates that they had a longer average length of therapy in comparison to the NPWT-K. When we think about transitioning our patients to the post-acute setting, we really need to come up with a comprehensive wound care plan. And this includes, where is the patient going, their discharge setting? Is the patient going home? Is the patient going to a skilled nursing facility? Is the patient going to a rehab? Is the patient maybe going to a friend's house? But we need to understand where the discharge setting is going to be for the patient. We also need to know who the care provider is. Is the patient going to be receiving home health? Is a nurse going to be coming out to the patient's home 2 to 3 times per week to do negative pressure wound therapy changes? Is there going to be a skilled nurse, maybe at a skilled nursing facility or a rehab hospital or at a long-term acute care hospital that's going to be managing the patient's negative pressure wound therapy upon discharge from the acute setting? We need to understand the products and resources that the patient needs. If the patient's going home, the patient's obviously going to need some supplies for home health to use when they do their negative pressure wound therapy changes, as well as the resources that they're going to need. We also need to understand the patient factors that affect wound healing: poorly controlled diabetes, immunosuppressive medications, patients with maybe rheumatoid arthritis, patients with poor nutritional status. We need to factor in, when we're coming up with our comprehensive wound care plan, those factors to make sure that we optimize the patient as best as possible. And last, we need to ensure that the patient has appropriate follow-up care, either when they get discharged from a skilled nursing facility or rehab, or when they get discharged from the hospital and they wind up at home, that they have the appropriate follow-up care with their surgeon or their wound care center or provider who's going to be managing that wound in the post-acute care setting. Patient factors that can impede wound healing. There are multiple things that can factor into wound healing, and there are patient factors that certainly can impede wound healing. And these can include age, nicotine or smoking, nutritional status, stress, overweight patients or body mass index, medications that the patients are on, immunosuppressive type medications, steroids, medications that can affect wound healing, patient's immune status. Do they have rheumatoid arthritis, or are they a transplant patient? These are factors that can impede wound healing. And chronic illness, diabetes, heart failure, lymphedema. Chronic illness can certainly affect wound healing. Now, it's hard for us to control all of these patient factors. One of the factors that we like to try and control is the nutritional status of the patient. We know that nutrition and wound healing is an important component to getting our wounds to heal. At our institution, we try and engage the nutritionists and our diabetes educators early on in the wound healing process. And we've come up with a sheet that we give to our patients that goes over a balanced plate for them and talks about the importance of nutrition and wound healing. We know that wound healing can require twice the amount of normal protein for a wound to heal. So our diabetes educators and our nutritionists aim to include protein at each meal. And we've come up with a balanced plate that we try to describe to our patients. And when we talk about building that balanced plate, we want to start with protein, have 0.25% of that plate that's dedicated to protein, have 0.25% of the plate that's dedicated to starches, but once again, being mindful of the carbohydrates. But we know that carbohydrates are a necessary source of energy for the body to heal. And then lastly, we want to have a plate that's half full of vegetables. We know that vegetables are rich sources of vitamins A, C, as well as minerals, including zinc and copper, which are essential components for wound healing. What patients need to know about negative pressure wound therapy. What I tell my patients about negative pressure wound therapy is something as simple as it just helps promote wound healing. And I explain to them that the negative pressure wound therapy device manages fluid or exudate. It helps remove cellular and infectious debris. It protects the skin around the wound. And one of the more important facts I like to stress to our patients is it actually can reduce the number of dressing changes that they receive. We know that dressing changes can be painful for the patient. And we know that negative pressure wound therapy typically is changed 3 times per week, so we can reduce the number of dressing changes for the patient. And lastly, I tell the patients that it can reduce swelling. We know that edema is an enemy to wound healing, and if we can reduce swelling, that can certainly help with wound healing. And these are just certain things that I share with our patients when talking about negative pressure wound therapy. Now, patients certainly can have concerns about their negative pressure wound therapy device, and I think it's important as a provider and our ancillary staff as well that we educate the patient and allay any concerns that they have about their negative pressure wound therapy system. They certainly might have some anxiety about the device. They're going home with a device that has some alarms, it has some noises, it has some lights, and they certainly can have concerns about that. And we need to allay their concerns with respect to negative pressure wound therapy and also what to do if something does malfunction. When we discharge patients home with negative pressure wound therapy, we certainly have to factor in considerations that affect the patient while they're at their home. We need to understand the patient's mobility. Can they get about by themselves? Are they a fall risk? Do they need some type of assistance device, maybe a 4-point walker or a cane so that they don't fall? Can they carry the device? We might want to engage physical therapy when we discharge patients home with negative pressure wound therapy as well, to gait train these people to prevent fall risk, but also to look at their home environment, maybe move furniture about so that they can get around their house a little bit more easily with this negative pressure wound therapy system that we have prescribed. Is the patient or caregiver able to manage the basic functions of negative pressure wound therapy? Do they understand the basic concepts behind it and they can troubleshoot any problems that do arise? Does the patient have any sensory deficits? Can they not see the negative pressure wound therapy system that might alert them with a visual alarm? Are they impaired through hearing where they might not hear an alarm that goes off? So these are things that we need to consider when we send patient home with a negative pressure wound therapy system. And then lastly, is their home setting safe for a negative pressure wound therapy system? As I shared, I have patients who literally live out of their pickup trucks, they live out of their cars, they live at friends' homes, they're homeless. So the home setting has to be safe for a negative pressure wound therapy system. And it also needs to be safe for home health that's going to be coming out to the patient's home. I've had home health agencies that have refused to see patients because their home environment just wasn't safe for them to go out to institute their negative pressure wound therapy system care after they were discharged from the hospital. Strategies to empower the patient. We certainly want to empower our patients with respect to negative pressure wound therapy. And one of the easiest ways to do that is educate our patients prior to their discharge. We want to teach them how to operate their negative pressure wound therapy system. We need to stress to them the importance of keeping the device on and keeping it charged. I can tell you I have a number of stories of patients that have turned their devices off for some reason or have not plugged it into the wall to charge it. It's very important that we educate our patients about keeping the device on and keeping it charged. We need to teach them how to change canisters if needed. They need to understand the basic alarms and noises that the negative pressure wound therapy system makes. They need to understand and recognize complications with their negative pressure wound therapy system, and when they need to be able to contact help for emergency and for assistance. We want to enlist the family and caregivers throughout the patient's wound care journey, and we certainly want to provide support resources for the patient. Now, these support resources can be through written documents that go over instructions on how to use a negative pressure wound therapy device, or if the patient's a little bit more savvy, we can teach them how to download apps on their telephone that help monitor their wound healing throughout their wound healing journey. But in short, we want to engage those patients and we want to provide information about their negative pressure wound therapy system so that they feel comfortable using this system and when they need to seek help or ask for help. I'd like to go over some of my negative pressure wound therapy case studies with you. I have 7 that I'm going to present. Our first case is a 53-year-old white female who was admitted through our residence clinic with a diabetic foot infection. She was taken to the OR the evening of her admission to the hospital for an IND by the vascular surgery fellow. Her past medical history was significant for diabetes mellitus, diabetic peripheral neuropathy, liver disease, hypertension, fibromyalgia, and depression. You can see on the photo on the right, she had a rather extensive IND. It went down to muscle, tendon, and bone. She has exposed structures. Her plain film x-rays demonstrated that she had osteomyelitis of the first metatarsal, and I was asked to see the patient the following day to come up with a treatment plan for her. Unfortunately, I did not have much to offer her other than a first-ray amputation You can see the patient photo on the left, that's her pre-op. Post-op day 1, first ray amputation. You can see that we have a large open wound, we have exposed structures, we have swelling, we have a wound that has exudate. This is a wound that we want to initiate negative pressure wound therapy early, and we did so in this particular patient at post-op day number 1. The patient was discharged with a negative pressure wound therapy device, and she was seen at the wound care center at post-op day 10, as you can see on the photo on the left. You can see that the wound still has exposed structures, still has a lot of edema. There's still a lot of depth to the wound. There's a lot of the wound that still needs to fill in. So this is a wound that we're going to certainly want to continue with negative pressure wound therapy, and that's exactly what I did. I saw the patient a week later, as you can see on the photo on the right, so that's post-op day 17. You can see there's still some depth to the wound. There's still a lot of swelling. It's still exudative. It's still a void that needs to fill in. So this is a wound that we're going to continue with negative pressure wound therapy. The patient was seen again at post-op day 31. You can see a dramatic change in the wound since post-op day 17. The wound has filled in quite nicely. The granulation tissue is to the skin line. Swelling has come down considerably. This is a wound at this point that we can discontinue the negative pressure wound therapy system and transition her over to an advanced wound care dressing to take her on to closure. And that's exactly what I did in this case. I used a collagen silver and ORC, advanced wound care dressing. And the photo on the right, you can see the patient at post-op day 60 is closed. She was fitted for a diabetic shoe and custom insole and has done reasonably well since that surgery. The second case I'd like to share is a 64-year-old male who was a direct admit from the wound care center. He had a chronic diabetic foot ulceration, diabetic peripheral neuropathy. He presented to the wound care center with ascending cellulitis of his foot, and he had osteomyelitis of the fifth metatarsal, which was confirmed by plain film X-ray and MRI. So the patient was admitted to the hospital with a surgical plan for a fifth ray amputation. These are intraoperative photos. The photo on the left, the fifth toe has been disarticulated or amputated at the MTP joint level. The fifth metatarsal is completely exposed. And then the photo on the right, the fifth metatarsal has been excised. The wound was packed and dressed, and negative pressure wound therapy was started at post-op day number 1. The patient was ultimately discharged with a negative pressure wound therapy system and was seen at the wound care center. The photo on the left, you can see, is post-op day 7. This is a wound that still has exposed deeper structures. There's still a lot of depth to this wound. There's still a lot of swelling within this wound. And there still is a lot of exudate coming from this wound. So this is a wound we're going to want to continue with their negative pressure therapy system to optimize it as best as we can. The photo on the right is post-op day 30. You can see that the granulation tissue is very healthy and it's robust. That deep void that you saw on the photo on the left has now filled in. And this is a wound that we can do a variety of things to take on to closure. I actually suggested a split thickness skin graft to this patient to be essentially one and done to get this wound closed. The patient did not want another surgical procedure, so the patient ultimately decided to use an advanced wound care dressing to take this on to closure. So we used collagen silver with ORC to treat this wound. The photo on the left is post-op 6 weeks. You can see that the wound is decreasing in size. We have very healthy granulation tissue present. The photo on the right is post-op week 11. The wound is almost completely healed. We have a smaller wound at the base of the fourth metatarsal now, since the fifth metatarsal has been excised, that needs to fill in. So we're continuing with that collagen silver and ORC advanced wound care dressing. And this is the patient at post-op 14 weeks. His wound is completely healed. He was fitted for an AFO brace, as well as a diabetic shoe and an insole. And the patient has done exceptionally well since his surgery and remains ulcer-free to this day. The third case I'd like to share is a 61-year-old white male with diabetes, diabetic peripheral neuropathy, hyperlipidemia. He had a diabetic foot ulceration with underlying bone infection, and he had presented to the wound care center with cellulitis. So he was admitted to our hospital for IV antibiotics, and we came up with a surgical plan of a first-ray amputation to treat his underlying bone infection. The photo on the left is post-op day 1. His great toe has been amputated. The metatarsal has been excised. We have a large open wound with exposed structures. This, once again, is a wound that is ripe. Negative pressure wound therapy would help decrease his length of stay and hopefully get that wound to close a lot quicker. The photo on the right is the diabetic foot ulceration post-op day 1 post-debridement. So we began negative pressure wound therapy on this patient post-op day 1. The photo on the left is post-op week 3. You can see that there's still a lot of swelling to the wound. If you were to stick a probe down the mid portion of the wound probed into the deeper structures. The wound was still exudative, so this is a wound that we're going to want to continue with negative pressure wound therapy. You can see on the photo on the right, since that infected bone has been excised, that the diabetic ulceration is healing quite nicely. The patient was seen at post-op week number 5. Granulation tissue has come up to the surface or to the skin line. There's no longer any depth to the wound. You can see that that peri-wound edema has decreased dramatically. The patient's wound care was transitioned over to an advanced wound care dressing, again, collagen, silver, and ORC to take onto closure. And you can see on the photo on the right that the diabetic foot ulceration is closed. This is the patient at post-op week number 8. His surgical wound is completely healed. The diabetic foot ulceration is healed. I apologize for the dry skin. I should have moisturized his foot prior to taking these photographs, but I didn't, and he has some dry xerotic skin, but ultimately the patient did go on to closure. He was fitted for a diabetic shoe and a custom insole, and he's doing well. The fourth case I'd like to share with you is a 71-year-old white male with diabetes, diabetic peripheral neuropathy, coronary artery disease, and he had osteomyelitis of the first metatarsal. The patient was admitted to the hospital, and he underwent a open first ray amputation. While in the hospital, he received IV antibiotics for his underlying bone infection, and he was treated with a traditional negative pressure wound therapy device while in the hospital. This patient was adamant that he did not want to go home with a wound vac. He wanted to be mobile. He wanted to do some things in his life where he was not tethered to a power cord or have to recharge a battery. So we kind of made a deal in the hospital that I would discharge him home, but I would like to use disposable negative pressure wound therapy on him to aid in closure. And that's exactly what we did do. This is the patient at the wound care center. You can see on the photo on the left, we're putting that hydrocolloid ring 1 centimeter away from the peri-wound. This is a wound that, in my opinion, once again, would benefit from negative pressure wound therapy. And fortunately, we have disposable negative pressure wound therapy that's available. The photo on the right is the mechanical negative pressure wound therapy device that's been applied. And this is a great system to employ or to use within your practice for patients that have small to medium-sized wounds that would benefit from negative pressure wound therapy with mild to moderate exudate. It's a mechanical device, so he's not tethered to a power cord. He doesn't have to worry about charging. The only thing he really needs to worry about is to make sure that the canister does not fill. The nice thing about this disposable negative pressure wound therapy system is that it's very low profile. It can be worn under clothes. It's silent. It gives some freedom back for this patient where they can resume some of their normal lifestyle to go back to work if needed. So this is a great option in utilizing negative pressure wound therapy in certain types of wounds when the patient is discharged to the post-acute setting. The photo on the left is the patient 3 weeks after using disposable negative pressure wound therapy. You can see that the granulation tissue has come up almost to the skin line. Edema is dramatically reduced. There's minimal, if any, exudate coming from the wound. And this was a wound that, once again, I used an advanced wound care dressing, collagen, silver, and ORC to take onto closure. The patient was seen at 7 weeks post-op. His wound is completely closed. He was fitted for a diabetic shoe and custom insole, and he has done well after that procedure. And once again, I just want to stress that disposable negative pressure wound therapy is an option for you to use in the post-acute setting, along with traditional negative pressure wound therapy. The fifth case I'd like to share with you is a 68-year-old female with diabetes, atrial fibrillation, hypertension, and osteomyelitis of the third metatarsal. The patient was admitted to the hospital. She was treated with antibiotics, and she was taken to the operating room for an open third ray amputation. You can see this is a large open wound that extends into deeper structures with exposed muscle and bone. And this is a wound where negative pressure wound therapy started early would be very helpful to help decrease the length of stay and also to help the wound heal quickly. We started negative pressure wound therapy on this patient at post-op day number 1. This is the patient post-op day 3. You can see that the wound has decreased in size to some degree just with 2 days of negative pressure wound therapy. She was discharged home with a negative pressure wound therapy device. The patient was seen at the wound clinic at 5 weeks post-op. The wound still has some depth, it still has some swelling, and it still has some exudate. So I elected to continue her negative pressure wound therapy for a couple more weeks. The patient was seen at post-op week 7. You can see that the granulation tissue has come up nearly to the skin line. There's mild exudate present, but the edema has decreased tremendously. This was a patient, again, who I switched to an advanced wound care dressing, collagen, silver, and ORC, and took her on to closure. The photo on the right is at post-op week 12. The patient's wound is closed. She was fitted for a diabetic shoe and custom insole and is doing well. The sixth case that I'd like to share with you is a 51-year-old Hispanic male with a diabetic foot infection from a dog bite. He failed outpatient therapy with oral antibiotics, and he returned to the clinic with cellulitis and a very boggy, crepitus-type wound. His past medical history was significant for diabetes mellitus, pancreatitis. The patient failed outpatient therapy. His wound looked a lot worse than the photo depicts, which you'll see at the next slide. And he was admitted to the hospital for IV antibiotics and was taken to the OR for debridement. Now, unfortunately, this patient had a necrotizing type of soft tissue infection, and it required a much more extensive debridement than any of us probably anticipated when we saw him in the clinic. He basically lost all of the dorsal aspect of the skin with the exception of his toes, and he wound up having to have a fifth toe amputation and fifth ray resection. This is a wound, once again, that is an optimal wound for negative pressure wound therapy. He has exposed structures. This is going to be a hard wound to heal just with conventional wound therapy. So we started negative pressure wound therapy on this patient early. The photo on the right is the patient post-op day 5. We have exposed muscle, we have exposed tendon, we have exposed deeper structures. We're going to want to continue with negative pressure wound therapy on an outpatient basis for this patient. The photo on the left is the patient post-op 3 weeks. We're basically covering the wound with Adaptic and applying the negative pressure wound therapy system over that. And we're starting to promote healthy granulation tissue and get coverage over the exposed muscle and exposed tendons. We continued with the negative pressure wound therapy for an additional 3 weeks, and the photo on the right is the patient at 6 weeks post-op. Almost all of the extensor tendon is completely covered with the exception of a small segment near the second MTP joint. Otherwise, we have very robust granulation tissue. The choice now is, what do we do to close this wound? With this particular patient, I wanted to be what we call one and done. So I had suggested a split thickness skin graft for this patient. It did require another procedure and another hospitalization, but I thought a split thickness skin graft, especially because of the location of the wound and the severity of the wound, was the right way to go. And the patient ultimately opted for that. The photo on the left is the patient in the operating room after the split thickness skin graft was applied. I had one of our vascular surgeons within our group harvest the split thickness skin graft. And then we admitted the patient to the hospital. We applied the wound vac intraoperatively, and the wound vac will stay on the patient for 5 days. The patient was seen post-op 5 days, and we took the wound vac down. You can see the vac on the left, and then the photo on the right is after the wound vac had been taken down. He has nearly 100% take of the split thickness skin graft. The patient was discharged from the hospital with home health. We were just covering the split thickness skin graft with Adaptic, and he was followed at the wound care center post-operatively. This is the patient 14 weeks from their original date of surgery. The patient's wound is 100% closed. And unless you count the toes, you really can't tell that the patient had a fifth ray amputation. The patient's in a diabetic shoe and a custom insole, and he's back at work. He's gainfully employed, and he's doing exceptionally well after that surgery. The seventh case that I want to share with you is a 60-year-old male with diabetes. He's had a prior stroke. He has a history of hypertension, hyperlipidemia, alcohol and tobacco use, peripheral arterial disease. He underwent an angiogram with intervention to improve his blood flow, and he had osteomyelitis of the right great toe. He was admitted to the hospital for IV antibiotics, and he was scheduled for amputation of his great toe. Now, initially, I was thinking about just doing a fish mouth incision around the base of the great toe, primarily closing him. We're doing a quality improvement program at our institution with our vascular surgery fellows, and we, on occasion, use intraoperative fluorescence imaging to assess the perfusion to our amputation patients. And we did use intraoperative fluorescence imaging on this particular patient. We injected him in with dye, and we're assessing the perfusion to that toe. Now, my initial plan for this patient was to do a fish mouth incision around the base of his great toe and close him primarily. After using the intraoperative fluorescent imaging, it changed my plan, and I had discussed with the patient preoperatively that he might require more extensive surgery, and he ultimately wound up with an open first ray amputation, and we applied the negative pressure wound therapy device intraoperatively, and that's what you can see on the photo on the right. The patient was discharged with a negative pressure wound therapy system and was seen at the clinic, and the photo on the left is 9 days post-op. The patient still has some depth to the wound. There's still some edema, and there still is some exudate. So we continued with his negative pressure wound therapy system for a few additional weeks. The photo on the right is 3 weeks post-op. The granulation tissue has come up nearly to the skin line. He has very robust, healthy red granulation tissue. You can see in comparison to the photo on the left, there's considerably less edema to the wound as well. And this is a wound that we can now use in advanced wound care dressing, collagen, silver, and ORC to take on to closure. Now, this patient is still under my active care. I just actually saw him in the clinic just a few days ago. His wound is almost closed. He's 8 weeks post-op. But this is a wound that I'm very confident that we can close with the collagen, silver, ORC dressing. He'll be fitted for a diabetic shoe and a custom insole with an amputation fill, and hopefully won't have problems moving into the future. Frequently asked questions regarding negative pressure wound therapy. I have patients all the time when we recommend negative pressure wound therapy. They have a lot of questions that they ask. And one of the ones that I hear routinely is, can I shower with my negative pressure wound therapy device? And what I tell my patients is, go ahead and shower with your negative pressure wound therapy device, but do it about 30 minutes prior to either their next appointment or 30 minutes prior to when the home health nurse is scheduled to come out to do their negative pressure wound therapy change. So yes, patients can shower with negative pressure wound therapy. We just don't want them to bathe with it in a bathtub where they're sitting, where they're at risk for potential infection, but showering certainly is an option for them. And we tell them that we don't want to keep that negative pressure device off for more than 2 hours. Other questions that patients ask is, what do I do if the alarm goes off? Typically, that means that there's a leak in the seal of your negative pressure wound therapy device or dressing. And I tell the patient that if they have a home health nurse, go ahead and call the home health nurse and see if the nurse is available to come out to repair or replace the dressing. If they're having their dressing changed in the wound care center, which is something that we occasionally do, I tell them that if it's during office hours, go ahead and call the clinic and see if they can come on in and have one of our wound care nurses repair or replace their dressing. And if they can't be seen by a provider right away through those teach-back methods that we talked about earlier in the talk, I tell them try and locate the leak and see if they can seal it with another layer of the clear film. Lastly, if they cannot keep their negative pressure device on without suction for more than 2 hours, because we know that can result in infection, I tell them to go ahead and remove the dressing and replace it with a gauze dressing, and to contact home health or come into the office the following day. Another question that my patients will ask is, when will negative pressure wound therapy be completed? And that's a really hard question. I tell them on average it's about 4 to 6 weeks, but the answer that I also tell them is that negative pressure wound therapy is completed when the wound has contracted and granulation tissue has reached the surface of the skin. But that's a real hard question to answer for the patient, because each wound is different and every patient heals a little bit differently. Another question that is frequently asked is, when should the patient call for help? And certainly the patient should call for help when they experience fever of 102 or higher, when they're experiencing diarrhea, they have headaches, sore throat, confusion, nausea or vomiting, dizziness or feeling faint when they stand up, warmth or redness that spreads around the wound, ongoing itchiness or rash from the drape, and of course, bleeding, any type of bleeding around the wound. They should call for help. So some closing thoughts on negative pressure wound therapy. Through our talk, we've learned that readmissions can be costly. They can be exceptionally costly, and our healthcare systems are looking at it, as well as CMS. Readmissions, however, can be prevented. We need to identify those patients at risk, our older patients 65 years and older, our frail patients, our malnourished patients, our patients on 6 medications or more, patients with unstable living conditions. We need to identify those patients at risk, and if we do so, we can prevent readmissions. We certainly want to initiate negative pressure wound therapy early. We know that it's not just indicated for our complex wounds that don't respond to initial therapy. We know that it can reduce length of stay, it can improve our wound healing, it can improve our patients' quality of life, and overall it can reduce cost of care to the healthcare system. We want to educate our patients with respect to their negative pressure wound therapy systems, and it's essential that we make the patient a part of the wound care team. Thank you, and this concludes our talk.